Hi, everybody.
Hello.
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 Hi. Welcome back. All right. So, as everyone's starting to gather, I know at least one person's going to be a little bit late. So, I want to jump in with talking about the formula that you all analyzed for your homework. And I haven't replied to all of you yet. I'm still making my way through, but great job so far on all of those I have read. So let's see. Let me get some things in order here. So then we're gonna after we talk about the formula, because it's one of my favorites, and I just want to say a few words about it, because it does have some herbs in there that are not commonly used in our materia medica, but I want you to know about it because it's so super helpful for pain. And then I'm going to say a few words about the midterm, but I'm going to wait until everyone gathers, and then we're going to do the wrist and hand today. So that formula is actually something called Zyflamend. And those of you who I've replied to so far, I've mentioned, I call this herbal Advil. And I'll hold it close. It's this. It's by New Chapter. And I will type it in the chat for you. It's called Zyflamend by New Chapter. And you can think of it like herbal Advil. So, you know, especially in the ortho world, we do encounter a lot of patients that are taking NSAIDs for pain, just for whether it's like after a hard day's work, for people that do a lot of repetitive activities and strenuous activity for their job, but also athletes too. And that's primarily how I use it, just after exercise and working out. And so I want to talk about it a little bit because it's an incredible alternative to Advil. If assuming, you know, that we're not dealing with pregnancy and things like that. But I think for the most part, people that tend to reach for the Advil for their pain, a lot of them, for the most part, can take this. We have to be careful with the blood thinning herbs in here, of course. But a lot of you identified, it's probably easy to identify our TCM herbs, right? So turmeric is in here. And there's 3 types of turmeric, right? We've got Zhanghuang, which is the one in here, Curcuma longa rhizome. And then we've got Yujin, right, and Iju. So those are all curcuminoid structures from the turmeric plant. So this one in particular, the Zhanghuang, it's great. It's the one that favors the shoulders, right? But it's anti-inflammatory and it reduces wind damp, painful obstruction, and other places too. But Eugen, I like to use when there's like traumatic injury with bleeding, and then Iju is good when there's like blood stasis with masses. So each one of our turmeric plants has a little bit of a different function, but in this formula in particular, it was the Zhanghuang that was in there. And then we've got Ganjiang, just because, it's in a bottle. It's not going to be shangjang, right? But ganjang orthopedically is actually really good for pain relief after exercise. So it reduces inflammation in that regard, and it also lowers blood pressure. And I think it contributes to the digestibility of this formula. And I know that some of the herbs in there in our Materia Medica, in combined with a lot of our like antibacterial, antiviral formulas, it can be hard on the stomach, but this is actually pretty digestible. And I think it's just formulated and balanced really well. I'm not as concerned about this being rough on the gut. I'm more concerned about Advil and Tylenol and NSAIDs wreaking havoc in the system, and you definitely see that. I mean, I get a lot of people that are popping ibuprofen daily, and then they end up with terrible GI symptoms. So this is, again, a great alternative. So yeah, we got the ganjang, and we've got the zhanghuang. We've got lucha, which is green tea. So that's not, I don't think it's a state board herb, so we don't talk about it a whole lot, but it's really good for cardiovascular health, and it lowers cholesterol, and there are a lot of herbs in this formula too that enhance mental clarity, and I think that's really great for exercise, right? That's what exercise does, but a lot of these also kind of like, clear the mind. And then hujang we have in here too. That cools the blood. It's also used a lot for joint pain. And again, it has like a really positive effect on cholesterol. It's also an anti-inflammatory. And then the Chinese gold thread, a lot of you caught that, was Huang Lian. And Huang Lian and barberry, which is in here, that's not really in our Materia Medica. It's called Fu Nu, but we don't study that one really. But those two have berberine in them, which is the active ingredient in Huang Lian and also in barberry. And berberine is it's pretty incredible in terms of being able to increase circulation, and also it lowers cholesterol, it stabilizes blood sugar. It's a strong anti-inflammatory, and I think, I've seen it used alone to reduce swelling and edema as well. But primarily think of it as increasing circulation. And then Huang Qin, you guys noticed in there, that's also a really good anti-inflammatory. The thing about Huang Qin and the thing about xyflamine in particular, if you research it, there's this positive sort of benign side effect. I don't think this is why this was formulated, but it was actually studied in reducing prostate cancer growth because it inhibits BPH. And it also has somewhat of a favorable effect on breast cancer too, because it suppresses abnormal androgens and estrogen. So it's got a really strong anti-inflammatory effect, but it also has this sort of side function of being an anti-cancer herb. And so rosemary is also an anti-inflammatory herb. It's called Mi Dia Shang in TCM. So anti-inflammatory, enhancing circulation as well. Holy basil. If anyone in Ayurveda wants to chime in, because there's some Ayurvedic herbs in here that are beautiful and amazing, but holy basil is tulsi. And, traditionally it's taken to kind of open the heart and prepare the mind for spiritual practice, which is great. And I think that's also an amazing thing before exercise. That's how I like to experience my exercise. But it lowers cholesterol, and it stabilizes blood sugar, reduces joint pain. And it's in our medicine, we can think of it as a kidney tonic, a heart tonic, and a spleen tonic. So again, I think it contributes to the digestibility of the formula as well. And then let's see, what am I missing? Oh, oregano. New Jur, I think is what that's called. But it supports the respiratory function, and it's also anti-inflammatory. So it's a very well balanced and awesome formula, and I really wanted you all to know about it. And yeah, it's great. Yeah, a lot of antibacterial properties. Oh, the pinyon for barberry. Let me see. Oh, I have all kinds of questions in here. Okay. The pinyon for barberry. It's Fu New. So Fu New is Fu New is barberry. So let's see. Questions. Okay, there. Oh, thank you, Brenna. You answered that for me. Yes, it's very antibacterial, and lactic acid sort of has an antibacterial function in our bodies. So yeah, I think that's interesting. I do like New Chapter as a whole, Javier. I think they're a pretty good brand. And I've worked and continue to some capacity to do a little bit of like contract work with some dietary supplement people out there. And I used to be in that world a lot more. And I think behind the scenes from like a regulatory perspective and just from like a credibility perspective, I think New Chapter is a great brand. So yes. Yeah, antifungal, antiviral. There's all kinds of really amazing side benefits from all of these. But the reason I really like New Chapter 2 is a lot of their formulas are very thoughtfully put together, and I'm pretty sure, I don't know for sure, but it seems like somebody who understands Chinese herbs is also behind the scenes. They've got to be, because I notice threads of our medicine and pairings in their formulas that we talk a lot about. So yeah, it's great. It's an awesome formula, and I'm happy to share it with you, and I encourage you to experience it yourself, as long as you're okay with all those blood movers. They have different versions of it. The one I gave you is the one I recommend. It's like a whole body version, but I think they have a nighttime version and all sorts of side versions, but it's good. And it's great to, I know we don't always have the bandwidth to add more information to our brains, but it's great to also learn about some of the more Western herbs or Ayurvedic herbs, and how those complement our medicine as well. So, Zyflamend, herbal Advil, introduce it to your patients and encourage them to try it in place of the Advil. And then one last thing about it, sometimes the way I take it personally is if I know I'm doing a big run or hike or something that I know I'm going to be sore, I'll take it before, and then again after, but it's great. I love it. Okay. So it looks like everyone's here now too. I want to say, oh, here it is. Zyflamend. Oops. Zyflamend. Okay. And you can get it at New Leaf, Whole Foods, Aptos Natural, Staff of Life, any of our natural food stores. You can get it online. It's a little pricey. This size bottle retail, which is only 60 capsules, and it's a 2-cap dose. So if you did it daily, this would be a month's supply. But here it is again for those of you who missed it. It's just under $50. So it's certainly more expensive than Advil, but much safer and healthier for so many reasons. All right. The midterm. I want to say a few words, and I want you all to listen very carefully. I want to be super clear about the goal of this class and the test and why we're here. And it's not to pass a test. Okay. I know that we have to do that in order to practice this medicine, but I think we're all here because fundamentally we want to help our patients. Right? So that's what I care about. I want this class, even if you never go on to specialize in any way, shape, or form in trauma and ortho, and if this is not at all of interest to you, I, at a minimum, want you to have a basic understanding as a primary healthcare provider, how to assess basic musculoskeletal conditions from head to toe, because I promise patients are going to present, no matter what they come and see you for, they're going to have aches and pains. And if you get some of these basics down, you're going to have oftentimes a better understanding than even a primary healthcare provider. They don't, they often will refer to a specialist and whatnot, but we have such an opportunity in TCM to help people with their pain. And it's critical to be able to assess conditions and screen for red flags. And, at the end of the day, does it matter where all the motor points are? I've said this a million times. No, it doesn't. We know when you come out of this experience, you're going to know a wide variety of places to needle in the body. And if you are drawn to trauma and ortho, you can refine that to be more efficient and perhaps effective in your ortho treatments. But we want to help our patients, right? That is the goal. So when I test you on things, I know I'm giving you a lot of information, and I'm trying to simplify and reel it back as we go. But I'm not going to ask you trivial little questions that are not going to help you in clinical practice. So, and even some of the conditions that are kind of less common, like, I'm really doing my best to try to write out what to focus on, but and the midterm and the final will largely follow those key points that I'm giving you. But I want you to make sure at all times your head is oriented towards learning information that's going to help your patients. Because if you're worried about passing a test, or if you're worried about making money, I promise you that is you're not going to be as effective in your practice. I promise you. And if you continue to experience this medicine with that goal in mind, that you want to help your patients as best you can, then you're going to pass your tests and you will have an income to support you, and those things will come, but just don't stress. And as you're going through your notes and as you're studying, I mean, really, if you're getting in the weeds and getting stuck in the details, really ask yourself, how clinically relevant is this? And maybe that's hard to tell, but I'm really going to try to help steer your focus towards the punchlines and the things that are really going to help you. But ultimately, when someone walks into your clinic shift or your office and they say, my neck hurts, I want you to feel comfortable knowing what to do and what to ask and how to assess that. So, or any body part, really. So, I just want to make that clear because I know there's a lot of stress about what to study, but I'm not going to trick you. This is different than yeah, that's true, Sebastian. Yeah, why are you doing what you're doing is what Sebastian said. That's a good question to ask yourself. I had one last thought and I lost it. But anyway, I don't want to overwhelm you. I'm not going to, I remember what I was going to say. So this is not for those of you who have taken review and assessment with me. That's a very different situation because that's all about passing your test, right? And that just, I've struggled with that because that is like kind of the practical, like, okay, how do we pass your boards? How do you think about that? How do you take all of this information and convert it from short to long-term memory? And how do you pass the board so that you can get out there and help people? And that is a very different situation because there is a lot of detail that you have to focus on and a lot of dusty corners of your mind that, we have to sort of uncover, shine a spotlight on, and practice taking a test that really does add multi-layered questions on top of one another. This is very different. So, I'm not going to ask you to memorize as much as I would in another class or in a review and assessment class. I hope that helps. It's a very general thing, but I really want us to all have the same goal, okay? And that's to help people. And that's just really important. It's more important than passing it. You're going to pass the test. You will. It's not going to be hard. If you're paying attention in class and you give it some time and you've been doing your, your movement practices, which thank you all for continuing to do that every week. I mean, use that as an opportunity to feel your own body mechanics as you're walking and running and sitting and all of those things, and think about how things get tangled up and how how to best engage these muscles so that we're supporting this amazing skeleton that and other tissues attached to it that we have. And it's just, trauma and ortho is such an opportunity to help people. And I guarantee that if you can help somebody with their shoulder pain or their back pain, they're going to come to you for a number of other things. So, and they're going to send their entire family and their neighbors. And I mean, pain is a huge problem. And biomedicine is great at trauma when it comes to emergency medicine and car accidents and, severe injuries that require surgical intervention. But how many people have chronic pain, right? I mean, you'll have no shortage of patients, I promise. If you are interested in treating pain, you'll always be able to find people who need you. Anyway, all right. Yeah, patience. That's true. That's funny. Okay. So, um, don't be afraid to ask me again what to study. I don't want to intimidate anybody, but I also just I want to say that, and I want everybody to make sure that that is your primary goal. Okay. All right. With that, does anyone have any questions, comments, grievances, hopes, dreams? Okay. Let's start with the wrist and hand. And some of this is going to be a little bit repetitive. So I think we can get through it pretty quickly. So don't be intimidated by the number of slides. I want to keep you awake during the lecture, but I encourage you to simplify the information into your own charts. Okay. Okay, here we go. Can everyone see me? Because I can't see you anymore. I can't see the chat.
Yeah, we can see you.
Okay, great. Good. Thank you. Okay, wrist and hand going down the body. So let's just start with some fun facts about the wrist, hand, and fingers, which I think is really cool. So I don't expect you to know off the top of your head how many bones make up the wrist, hand, and fingers, but does anyone want to take a guess?
30.
Ooh, very, very close. Very close. 28. It's pretty incredible. So a lot of room for injury, right? And a lot of complicated little structures. So as we know, we studied the elbow, and then we have the radius and ulna, and then we have this hand that's attached. So what do you think? Is the ulna technically part of the wrist? Because
No.
because I'm asking, you'd probably guess no. But before that was called to your attention, you might guess, yeah, down here, the ulna and the radius, especially because we have the styloid process here where SI6 is, right? So technically, no. And I'll show you a picture. It's really interesting. The ulna doesn't actually make contact with any of the carpal bones in the wrist directly. There's a huge space there, actually. So it only articulates, I don't know if you can see my hand, it only articulates with the radius at the distal radio-ulnar joint. The radius on the thumb side continues, and that meets the carpal bones, but the ulna really doesn't. So in this way, it functions to pronate and supinate the wrist by rotating around the radius, but it doesn't technically go all the way up. So I think that's pretty cool to think about, or interesting. I don't know if it's cool, but it's interesting, right? Okay, so how many bones make up the wrist? If you remember, I'll give you a big giant hint. There's 4 on the bottom and 4 on the top. So that makes 8. Yay! Good. So 2 rows of 4. And it's not a straight row. It's kind of like a curved row. And then how many bones make up the palm? That's pretty easy. It's 5, right? So we have 5 metacarpals. And then the fingers, that's where things get a little crazy. Then there's 14 bones that make up the fingers. There's 3 in each of our fingers and 2 in the thumb. So it's complicated in there, but it's good to kind of have a rough idea of where these bones are punctuated. Just because it helps us, it helps guide our needles always, right? If we know what's underneath. So again, this isn't an anatomy class. I'm not going to grill you on anatomy, but I will tell you, if your interest in trauma and ortho progresses after the pressure of passing the boards and memorizing whatever it is you need to know for that is behind you, I encourage you to always continually just explore anatomy, because that's going to help you. That has everything to do with where we put our needles and how fearless you might be about placing those needles in sensitive areas, right? Because if you know what's behind there and you know what you're dealing with, for better and worse, it can just make you kind of a more efficient needler. So, am I going to ask you all of this? Probably not. I'll try to remember to jump in there with fun facts about the midterm. Okay, so range of motion, we want to get this straight. Okay, so wrist extension, or sorry, flexion and extension. I think you can see my wrist. Then we talked about this a little bit last time, but we have ulnar deviation. So that's, and that's similar to valgus and varus stress, right? So ulnar deviation would be similar in the elbow to valgus stress. You're going in an ulnar direction. Is that right? Sorry, I'm in anatomical position. Yeah. And then radial deviation is towards the radial side. So we want to get those straight. Extension and flexion of the fingers is similar to the wrist. So extension is up and back, just like the neck. And then flexion is down and curled, gripping, right? That's flexion. And then the thumb has, and then for the rest of the fingers, we've got, it's similar to the shoulder, right? We've got abduction, where our fingers are nice and open wide, and then we got abduction, adduction, adduction, where they're close to the midline. And then the thumb has its own little range of motion. We've got these amazing opposable thumbs, don't we? So thumb adduction or abduction and adduction is just like the rest of the fingers, right? So if you're just talking about the thumb, abduction is out. And then extension, actually, that would probably be more thumb extension. I'm sorry. So abduction of the fingers and then extension of the thumb, right? And then flexion of the thumb is kind of a cross. It's like horizontal adduction. And then going all the way to the pinky is opposition. So we've got this like ability to go in multiple directions with the thumb, and it's a commonly injured joint. So I just want to run through that quickly, because sometimes when we're talking about ortho testing or whatever it is, we use these terms, and I want you to at least have a reference for what that means. We don't necessarily have to watch this right now. It's kind of a boring little video with our friends from Physio Tutas. Maybe I'll play it during the break, or you can watch it on your own. It's really just going through all those ranges of motion. So maybe it's 3 minutes. It's easy, but it's like, I don't think this is telling you much that you don't already know, but it's actually nice when, if someone has a wrist problem and you're thinking in the back of your mind, oh my gosh, I can't remember anything about the wrist and hand. What do I ask besides, location, duration, OPQRST? All right, let's explore some range of motion, right? So as you're going through all of these ranges of motion and documenting what might hurt in the wrist and hand, you can be thinking about, where you're going to go from there. But this is just a good, simple assessment. And you can apply this to any joint, flexion of the neck, extension, rotation, lateral flexion. So we'll watch this closer to the break. So those of you who want to tune out, you can. But I want to kind of get through some of the other stuff because it's our last lecture before the midterm. So just as a recap on the bones of the wrist, I'm not going to ask you in detail what all of these are, but I want you to know that the bones of the wrist are the carpals, right? They're the carpal bones. And there's some really important landmarks. The bottom layer, so the proximal row, we have the scaphoid, and scaphoid fractures are pretty common. So we'll talk about that. But you've got the scaphoid and the lunate, and those articulate directly with the radius. So do you see this big space between the ulna and these carpals? There's connective tissue that links those, but they don't directly articulate like they do with the radius. So, and then we have the triquetum, which is here. And then we have the pisiform bone, which is right on top there. And then we have on the top row, we have over here the trapezium. And then we have the trapezoid. They all sound like geometric shapes, right? They are named after their shapes. And then we have the capitate right in the middle. And then we have the hamate. And the hamate has this little hook. So yeah, these are the carpals. And a lot of muscles attach there distally. All right, and then we've got, so the rest of the hand. So we have all of these at the bottom, which we just talked about, the carpal bones, not the arpal bones that got cut off, sorry. But the metacarpals are the ones that make up the palm, right? That's where we find P8, heart 8, and then moving up, we just talked about there's a lot of different bones that make up the fingers, right? So we've got the phalanges up here, and we've got proximal, middle, and distal phalanges with the exception of the thumb. And we've got the metacarpal joint. So when we talk about the metacarpal or the MCP joints, the metacarpal phalangeal joints, that's like where the knuckles are, right? So it articulates the palm and the bottom of the fingers. And then as we move up, we've got the pips, the proximal interphalangeal joints, and then we've got the dips at the very top, the distal interphalangeal joints. And the dips and pips are, I refer to those a lot when people are talking about pain and in rheumatoid arthritis or in conditions where you're noting swelling. It's good, it's good to know this language when you're charting so that you can be clear about which region of the body you're talking about. So it's not just like finger, toe. So the dips, the pips, and the MCP joints are good to get straight. All right. Now, if I'm going to focus on anything, this is probably the most difficult part about the hand and the wrist, but this is the part I'm going to pick on. So tune your attention. And even if you forget the details, I promise if you spend some time going through this, at least you'll know enough to know the difference between different nerve pathways. And this is a really big deal in the hand because a lot of people will report, they'll come to you and they'll say, oh, my neck hurts. Okay, most people's neck and shoulders hurt, right? From posture or whatever it is. And then so you assess the neck and you ask, does it refer anywhere, right? And they may or may not, they may say yes, they may say no. If you ask about numbness and tingling, they may say they have numbness and tingling in the hand. And so you have to be able to distinguish between a cervical nerve root compression or a peripheral nerve root compression, either in the brachial plexus here in the armpit, in the elbow, in the wrist, or anywhere along the pathways where these nerves kind of get squished. And we're going to look at that from head, neck to hand. But these nerves that sort of traverse the entirety of our body all start somewhere in the spine, but then they sort of separate into different segments and behave differently down the line. And that gets really, really complicated. So we're not going to look at this level of detail in all these body systems, except when it comes to the hand, because some people will come to you just with numbness in the hands and or fingers. So why does it matter? It matters because if someone has a problem coming from the neck, one, that's a more serious thing, because that could lead to irreparable disability. If a nerve root's affected or the spinal cord's affected, you don't want someone to lose motor function of their arm or hand. But if it's not coming from the neck and it's coming from somewhere else, you have to be able to treat it accordingly. So if someone's numb in the hand and you just treat the hand and it's coming from the neck, your treatment's not going to be effective. So I want you to spend some time as you're reviewing the neck, compare this to the radial, median, and ulnar nerves that we're going to talk about now. So this is kind of a visual. And if I had finger paint, we could paint our fingers like this. Or you could do that when you're studying, something like that. So here's kind of a breakdown. And again, this is why it matters, right? So first, let's talk about the radial nerve. The radial nerve is most commonly compressed in the axilla. So this is the nerve that gets a little bit traumatized when people have crutches and they can report numbness in the hand. So it's always important to ask, well, where in the hand, which fingers, right? So if the radial nerve is damaged, it could lead to wrist drop. And there's this teeny little picture here for you to see what that looks like. So I want you to focus more on the sensory distribution of these pathways. It's good to know how the motor function works. The radial nerve extends the wrist and fingers, and it supinates the wrist. But the important thing to know is where on the hand in that sensory distribution the radial nerve travels, because it's different than the neck. It's similar. So, but what I will say just generally about the difference between the neck and some of these peripheral nerves is that if something's compressed in the peripheral nerve distribution, it may be different on the palm than it is on the dorsum of the hand, where in the neck it might not be, right? It's just kind of generally, my pinky and ring finger, my middle finger. And this makes a difference too when it comes to carpal tunnel, because like I said, you're going to have a lot of people that come in saying their carpal tunnel's acting up, and 9 times out of 10, it's not really carpal tunnel, but it might be. So you want to know. Okay. So here's a picture. The dorsal side of the hand, so the back of the hand, and the radial nerve pathway is this blue here. So it's the thumb and index finger. Is that right? This is the proximal. Okay, the proximal thumb and index finger, not the tips, and the web space between the thumb and index finger. And also, you know, the middle finger is included in this picture. I will say the photos that I had in trauma and ortho were very different than this. And sometimes even when you're Googling cervical nerve pathways and peripheral nerve pathways, you're going to get some contradictory information. So I'm not going to, yes, I want you to focus on this, but I'm not going to ask you anything where there's debate. Okay, so think thumb and index finger, not the tips of the fingers, very little on the palm side. So it's kind of this like thumb and index finger region on the dorsum, and like very little to none on the palm side, even though there's a little bit of blue down here. The median nerve is the most common that you're going to see. I think the radial nerve is the least commonly affected. So I'll tell you now, I'm not going to pick on the radial nerve, but it does include the thumb on the radial side. I think that's pretty intuitive, and wrist drop is associated with that. The median nerve is where you're going to see carpal tunnel, and if it's affected to the point of atrophy, you're going to see ape hand. And so the thumb kind of like curves in a little bit, or it just kind of it adducts, and then you may kind of see the pinky and ring fingers start to contract a little bit. And this, of all the pathways, is the one I want you to know the most clearly. So it's on the back of the hand, it's the tips of the fingers, most of the fingers. So the thumb, the index, and middle finger, and then it's half of the tip of the ring finger. And then on the palm side, it's the whole thumb, pretty much, the index and middle fingers, and then half of the ring finger, and half of the palm. Yeah, it goes all the way down the palm on the palmar side, but it spares the tips on the dorsal side. So that's kind of a weird thing about the median nerve. And then the ulnar nerve, you're going to have, that's going to be compressed. It can be compressed in the wrist. We'll talk about where the Guyan Canal is, but that nerve, if that's affected, you're going to have a claw hand, and it's going to look a little like that. This is ring and pinky finger. Technically, it's half of it, but I want you to just think of it as ring and pinky. And then like the hypothenar region, the ulnar side. You can redo this chart, but I'm going to show you a picture that might be a little bit more clear, or that you can compare, right? So the peripheral nerve entrapment can start in the brachial plexus. So let's start at the top. The cervical nerve roots, we talked about those pathways. So C6 being the thumb, C7 being the index and middle fingers, and C8 being the pinky and middle fingers. And see how it's the same. It's the exact same on the back of the hand and the front of the hand. So that's very easy. So C6, C7, and C8, those are the three you'll want to kind of like overlay when you're looking at the radial, medial, and ulnar nerve pathways. The standout being that on the back of the hand, the tips of the fingers are going to be affected by the median nerve. So that's unusual, right? And then as if someone's saying, oh, my hand is numb, you're going to ask, take them through the range of motion of the neck and see if that triggers any numbness or tingling down the arm. And if it doesn't, you might consider the brachial plexus, right? So when we talked about the shoulder, some of these spinal nerves that come out of the neck, join together, goes through the thoracic outlet in the shoulder, and the brachial plexus is actually formed by the radial nerve, the ulnar nerve, and the median nerve, as well as the musculocutaneous nerve. And I think one more. The subclavian artery for sure, but that's all up here in the clavicle. So when you're talking about thoracic outlet syndrome and numbness and tingling that might refer down the arm from the shoulder, it's very unspecific because that nerve bundle gets all squished together. So in the neck, it's very clear. It will reach certain fingers on the front and the back kind of equally, roughly. And then as it gets squished here in the brachial plexus of the shoulder, or in the thoracic outlet of the shoulder, you could feel it through the whole hand, right? The whole bottom of the arm. It might include all of the fingers because those nerves are kind of squished in a bundle up here. And then as you make your way down to the hand, if it's compressed just in the elbow, it might just be the pinky, right? So these pictures kind of illustrate the difference between the two. And hopefully what I didn't check is whether these pictures matched the other ones, but because again, there's a little bit of contradictory information out there. But for the most part, this looks right to me. So yeah, half of the ring finger for the median nerve and the ulnar nerve. And then the tips of the thumb, finger, and middle finger for the median nerve. So this is what I was just talking about. So this kind of web here, that's the brachial plexus. That's this complicated nerve pathway from the neck all the way down to the tips of the fingers. So if you start over here, C5, C6, C7, C8, T1, verbally, I literally spelled out those pathways, right? So sometimes it's easier to see a picture of it, but there's segments of the lateral forearm, and going down to the fingers from the neck, and then they converge through the neck, through the clavicle, and then the that's right, the axillary nerve was the one I was forgetting. So all these little peripheral nerves get squished in a bundle up here, and then they branch out down the arm. So I'm not going to focus on the musculocutaneous or axillary nerve. The axillary nerve gets compressed a lot in the shoulder with like subscap injuries. It innervates the deltoid and the teres minor. So a lot of times in the shoulder, people will say, I just have this ache kind of around my deltoid that kind of refers back here. That's the axillary nerve. That's up, that's the one that we want to be cautioned with when we're needling heart 1. But, if there's compression up in the shoulder, you're going to kind of feel it all in that area. And then the median, radial, and ulnar nerves branch out further down. So the median nerve is the carpal tunnel nerve. So you really want to know the tip of the thumb, index and middle fingers on the back of the hand, the thumb, the index and middle fingers, and half of the ring finger on the radial side of the palm. And that, my friends, is carpal tunnel, and we'll talk about that. But that's the difference between a nerve getting compressed in the wrist versus higher up. C7, for example, would just be the middle finger and maybe the index finger. We're not talking about the ring finger at all. So yeah, you can follow that through. And I just remember when I was in, and some of this might be familiar to some of you already, but when I was hearing all of this for the first time, I remember going, what? So don't stress again. I want you practically to know the difference between some of the conditions we're going to talk about, like carpal tunnel and ulnar neuritis in the elbow, and distal ulnar neuritis, which we'll talk about, and how that varies in the neck. And I want you to recognize, zooming out, that there's a difference between a nerve root compression in the spine and something getting squished further down the line. Those are different ways of treating. Those are different diagnoses. So spend some time with those nerve pathways, and that's really going to be the most complicated part of the hand and wrist. We talked a lot about the muscles last time, in terms of the flexor muscles in the arm that we treat in elbow pain, actually being responsible for more wrist movement, right? So some of this is a little bit of a review, but these muscles here in bold are the ones we're going to look at again. And these are the ones to just kind of, keep an ear out. It's really, if it starts with extensor, it extends the wrist. And if it starts with flexor, in most cases, it will flex the wrist, right? So that's not hard to draw a line through. Ulnar deviation and radial deviation, you have to have participation from one flexor and one extender to do that. So that's worth noting. And ulnar deviation is going to focus on the ulnaris muscles, where radial deviation is going to recruit the radialis muscles, right? So you need one flexor and one extender to participate in each of those directions. So I just want to call attention to that in terms of biomechanics. And then finger flexion, finger extension, thumb flexion and adduction, and finger abduction and adduction. That gets a little more complicated. I'm going to mention some of these that are in bold because we have really great access to needling these. So I want you to kind of know where that is. But I think that the takeaway here and the big question, how do we help our patients, right? Finger flexion, pain with finger flexion versus pain with finger adduction and abduction, right? That's kind of two different sets of muscles and structures that you might aim for with your needles. So I want you to kind of be aware of some of the more accessible muscles and what they do, so that when you ask your patient, well, what makes it hurt? Finger flexion and extension are more common, I would say, than abduction and adduction. But you might think, oh, the lumbricals, I know how to needle those. Anyway, let's look a little bit. So remember this slide that was in our last lecture. The flexor group, they all attach at the medial epicondyle and function to move the wrist and hand, flex the wrist and hand. So I think, to be very clear here, I want you to know that the flexors of the arm, the forearm, which is technically called the antebrachium. This is the brachium and this is the antebrachium. So the forearm, the flexors attach at the medial elbow. So I want you to know that, as opposed to the extenders attached to the lateral elbow. And that's really the extent you need to know there. I'm not going to get too nitpicky about each insertion and origin, but I want you to know generally the flexors are on the inside versus extenders being on the outside, or medial versus lateral. So there they are. And I put the motor points kind of all in a row here so you can generally see where they are. They're in a nice little diagonal line about halfway-ish, well, probably maybe 3/4 of the way down from the elbow in the diagonal line. So if you kind of generally know where those are, you can find some Aki Asher points along those pathways and likely find a motor point. And I'm wondering, let's get through the flexors and then we'll jump back in. Or maybe I'll give you a break. I feel like I just bombarded you and overloaded you with a lot of information. So maybe a break would be good, just for a little bit. Ooh, yeah. Good question, Molly. In TCM meridians, that would be a really good way to translate maybe some of those nerve pathways. It's not as straightforward. I think generally, you know, the heart and small intestine follow the, you know, ulnar pathway. The lung and large intestine are more radial. But when it comes to, I know the anatomical position is tricky when you talk about medial and lateral, because when we're in anatomical position, right, our hands are like this. In biomedical anatomical position and in TCM, we're like this. So as much as I love to connect the TCM and ortho dots, which we can, sometimes some of these details, there's a lot of crossover and you can't always explain them exactly that way. And this class, I want us to be comfortable describing locations of the body in medical language. So I find with the hand and the arm, sometimes it's easier to say radial and ulnar than medial and lateral. Just because, you know, most of us know the ulna is the pinky side, right? Which is actually the medial side. And then, yeah. Yeah, the intermedial aspects, they can be Xiaoyin, Xiaoyang for sure. So I'm leaving sort of pictures of the channels through the lectures as well. It also depends on what channel pathways you're looking at. And I think for this class, focusing on like the sinew channel pathways, that is kind of where we're aiming our needles, right? But some of the more interior pathways kind of deviate and dart around in and out and all around. But yeah, you're right. Xiaoyin, Xiaoyang. But again, it's not always that straightforward when we're talking about a peripheral nerve, because the back of the hand, meaning the dorsum of the hand and the palm of the hand, are going to feel different with different nerve pathways. And our sinew channels and our TCM channels, they largely follow like the spinal nerve pathways. But, you know, when we're talking about the nuances of the median nerve, there aren't any channels that that just address the tips of multiple fingers, right? Then we're talking about portions of several channels, and I don't want to make it more confusing than it already is. So that's the funky thing about the wrist and the hand is the back of the hand and the palm of the hand often have a different nerve distribution than what we see in the spine. So yeah, Sichuan, those points. That's true. Yeah, the extra points. I think when you study acupuncture points, and the Bashya too, the Bashya, you can actually access a lot of the deep muscles in the hands. But yeah, the tips of the fingers and the webs, when we're talking about the Bafeng and the Bashya, allude to that, definitely. I love that you're connecting the TCM dots. That's what we want to do always, always, always. So yeah, let's see. Let's have a break. And let's see, 40. Let's meet back at 2:50. And I'm going to play that little video. And if some of you want to keep one eye on it, you can. But I'll give you a couple extra minutes. Meet back at 2:50. Otherwise, you can tune out, have a snack, use the restroom, whatever you need to do. But I'll go back and play that video. Let's see. Here we go.
This is going to be a video on active range of motion assessment of the wrist and hand. Hi and welcome back to Physio Tutors. During active range of motion assessment of the wrist and hand, you're going to evaluate movement in several joints: the radio and ulnar carpal joint, the carpometacarpal joint, the metacarpophalangeal and interphalangeal joint. You are also going to include the distal radio-ulnar joint in this assessment. During active range of motion, your patient can perform the movements in both limbs at the same time, and you can directly check for differences. Then, with the arms flexed to approximately 90 degrees, ask your patient to rotate the forearms internally for pronation and externally for supination. Make sure that the arm is not further adducted during supination to give the appearance of increased supination. To assess active range of motion of the wrist and hand, have your patient in sitting position with the forearms resting on the treatment table. We're going to start with wrist flexion, followed by wrist extension. Then we're going to do radial deviation. Make sure your patient is not compensating from the forearms. And then we're going to do ulnar deviation. Next up, we're going to do finger flexion. So simply ask your patient to make a fist. Consequently, finger extension. So ask your patient to spread the fingers as much as possible. For finger abduction, your patient can do the same thing. Then we're going to do finger adduction. So ask the patient to bring the fingers together until they touch each other. Now we're going to look at the thumb because it's something special. First, we're going to do thumb flexion, followed by thumb extension. Then we're going to do thumb abduction, followed by thumb adduction. Lastly, we're going to do opposition. So ask your patient to touch the fingertips of thumb and pinky. Okay, this was our video on active.
Okay, that was a quick little video for those of you who were watching it with one eye. It's really pretty intuitive, I think, but it's just good to go through those ranges of motion. Okay, I'll see you back in 10. Okay, here I am. I'm back. And looks like most of you are too. So Frederica had a great question. When do we actually start adding resistance to range of motion? So this is where things can get really complicated and sensitive when it comes to trauma and ortho. And there are ways to test all of these little tiny muscles individually. And we're only really talking about resisted range of motion in really kind of significant muscle groups. But here's kind of the general answer there. It's really, really important to test range of motion and strength. So myotome function when we're assessing the neck and the muscles that are sort of associated with those spinal nerves, because of the fact that those nerve pathways can be both motor and sensory. So the spinal cord contains the motor and sensory fibers, kind of like a donut, not exactly circular and round, but the motor and sensory impairment can go together, and usually the sensory part is the first to get irritated because that pathway is a little more superficial, and the motor part of the spinal cord is a little deeper. So if you have a little bit of compression, let's say in the cervical spine, and you feel it sort of just refer to the deltoid might be nice and strong, but if you don't treat it, that motor function is gonna start to that might start to go, right? So you want to kind of see how advanced something is by adding resistance to some of these manual muscle tests. And that's particularly helpful in the spine to assess how far or how advanced or how serious some of that compression is. Now, when we're talking about peripheral nerves, it gets a little bit more complicated because those branches can split off. Some of them can share sensory and motor function, and some of them can just be sensory, and some of them can just be motor. So it's super, super complicated. And I think that all of the ortho tests that we're focusing on in this class that have a name that might weave their way into your board exams and whatnot, those are assumed to be muscles that, you're going to have referred pain, but we're talking about structures that do have sort of a like a motor involvement. It's not just purely sensory, right? So in the fingers, for example, you may be able to test resisted flexion and extension to get a sense of what like the lumbricals or the interosseous muscles are doing. And if those are nice and strong and those don't necessarily reproduce pain, then maybe we can assume that it's a sensory nerve pathway, and we may still treat those physical structures, but it's not going to give us a diagnosis. So it's a complicated answer, but I think that one, if you know how to isolate and test a muscle that hurts, go for it. And if the answer to that question is, oh yeah, resisted range of motion is painful when I do this, that kind of confirms what structures are involved in the pain pattern. So it would be nearly impossible to, there are tests for every one of these flexors and extensors in the arm. Some muscles, just quite frankly, because I've asked about this a lot too in clinics and whatnot. Well, how do I test that? And how do I test this? Sometimes it's really not possible to isolate muscles and motor strength of a muscle in isolation, because that's not really how we move our body. Sometimes, we recruit them in groups. And so in the shoulder, it's really easy to isolate, and put the supraspinatus in a point of vulnerability by doing the empty can test. And that, that stresses the muscle and it stresses the tendon, and we can kind of isolate there. But not every muscle is possible to do that. So you can get information about groups of muscles by testing some of these simple things like resisted extension and flexion, but of the wrist in particular. But that's going to give you a sense of, it's not going to tell you which muscle is involved, right? But it might tell you what group of muscles are involved in that pain pattern. And then you can treat multiple ones, or you can treat attachments, or whatever you can reach safely. I'm sorry that it's not a super straightforward answer, but I think when looking just at the wrist and some of those movements we went through, the difference between being able to resist, and we'll see one of these ortho tests that we're going to talk about. It can help you kind of determine, again, if the spinal cord's involved based on motor strength and control. So if something in the neck is really injured, you're likely to have less motor strength than if the peripheral nerve is damaged. So I know that's a mouthful, and I'm sorry about that. And sometimes I think the answer to that question will become clear the more you review this information. And sometimes it's kind of hard. It's like when someone asks, people ask questions about acupuncture all the time, right? Like, how does acupuncture work? I love that question. It's a loaded question, right? So you can answer it generally, but oftentimes you might find yourself rambling like I am, because the answer to that has so many keys to so many doorways and so many sort of like different answers based on X, Y, and Z. So yeah, it's complicated, but I do think it's always helpful if you want to add a little resistance to a particular range of motion. If you know what that implies, go ahead and assess. Yeah, it's true. It is circular logic. Okay. So yeah, I'm going to keep thinking about that question, and a lot of your questions I continually think about as we talk, and I might weave in more specific answers as it relates to specific structures. But again, I know that the nerve pathway stuff is a little overwhelming. I don't want you to stress about it. And again, remember this slide, words and verbal explanations sometimes are like, that will come when you have the picture of it in your mind. But to talk it through and connect a picture based on the words isn't always helpful when the words are complicated. I hope that makes sense. But go back to this picture, right? And compare the hands here. So C6, it's just got a thumb, right? And look how much of the arm C6 refers to. That's not the case when we're talking about the radial nerve. The radial nerve has a very, very minor, almost inconsequential, some sources would say not at all involved in any sensory distribution on the palm side. It's the median nerve, right, that grabs the thumb too. So that's very different than the cervical nerve pathway, where C6 or C7 is the finger, the index finger and the middle finger. And that grabs the whole, both of those fingers, right, on both sides and travels up the arm. So maybe on the palm side, it might be similar in the sense that it covers a segment. But one of the ways you can check for sensory function, even if you're not sure, you know, I talked about those little, they're like the little point, what are they called? Someone out there might know, little point discriminators that have different widths of distance between them. And that allows somebody to perceive whether they're feeling 1 point or 2 points on the skin. And the closer together the distance of those 2 points gets, the more fine sensory information you have, right? So if the static on the line is such that you can't really tell, you might only feel what pressure from one source, even though the stimulator has multiple prongs in that area. But you could just use alcohol, and it should feel equally cool and wet on both sides. And if it doesn't, then you can assume that there's a little bit of a sensory deficit. So you can swab the tips of the median nerve pathway, or you can swab, you know, different segments of the cervical spine in those pathways if you're really not sure. So anyway, this is a good picture to spend some time with, and then worry about all the words, you know. If you have it straight in your mind, and you can call it digits, you can call it 5th digit, 4th digit, 3rd digit. I'm trying to use, you know, thumb, ring, pinky finger just for our conversation. But when you're charting, you know, you want to probably use more formal medical language. Okay, so let's move on. So muscles, don't get overwhelmed. I'm including some of these so you can see where our wonderful TCM acupuncture points actually tap into these aspects of the hand and fingers. So the flexors, we're going to fly through the anatomy because this is not something I'm going to pick on. But again, generally the flexors attach to the medial elbow. So to partly answer your question, I believe there are manual muscle tests for flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. I'm pretty sure Matt Callison's book has a lot of those in there. I don't do that in practice. You know, now that I have that book, I'm going to kind of look in there and see how I might, you know, manual muscle test a little bit more sensitively, but just generally resisted flexion of the wrist may cause pain in the elbow, right? In the medial elbow. So that's good to check. If you resist flexion of the forearm, you're probably going to get more information about the bicep. So yeah, again, it's so complicated. But it doesn't, for the purposes of this class, it's too much detail to tease some of these out. but here they are, and there are ways to test them uniquely. And this, we're talking about a trajectory from the medial elbow, kind of between heart 3, pericardium 3, and lung 5, right? So if we're drawing a line there, and then we draw a line kind of down to heart 7, P7, and lung 9-ish, that's kind of the pathway that these muscles follow. But the belly of the muscles are closer to the elbow. So you can see that in this illustration. So 3.5 to 4 Sun distal from P3. And again, it's kind of this diagonal line here, right? So it's about, yeah, maybe about a third, like 3/4 of the way up the forearm, or a third down from the elbow, is where you're going to feel the bulk of these muscles. And you know, this matters because one, if you treat these attachments in elbow pain, you could get some relief there. But because these move the wrist, if you try to treat some of these muscles that move the wrist further down the wrist, look at what you're going to hit. You're going to run into all these tendons and nerves and ligaments. I mean, the bulk of the muscles are higher up the channel. So I'm just kind of pointing this out so that you kind of can think about when you're needling. So palmaris longus, we're familiar with this tendon, right? So it flexes the wrist and elbow, and then it tightens the connective tissue in the palm. It makes it nice and taut. I'm not going to focus on a lot of these actions. I want you to know, generally that they flex the wrist, but all these little nuances, that's maybe where manual muscle testing would really refine exactly what structure was involved. And then you can, target that individually. And then flexor carpi ulnaris is on the most ulnar side of this line, and you have to needle it a little bit more superficially. But again, it's involved in flexion of the wrist and adduction of the hand. So if flexion of the wrist is painful, you might think about needling these. If there's pain in the medial elbow, you might think of needling these as well. And again, this probably partly answers the question of manual muscle testing to determine whether or not a muscle is involved in elbow pain versus wrist pain. Yeah, okay. These are kind of all over the place, but again, we have a diagonal line about a third of the way down, plus one little area where we can sneak in to extensor carpi radialis brevis. So these are the extensors, and there is one manual muscle test that we did briefly kind of talk about. I took it out because I didn't want to, give you too many tests to worry about. But if somebody had elbow pain, for example, and you wanted to see if at least extensor digitorum communis was involved, you could do resisted middle finger extension. So you're forcing it into flexion while they're trying to extend it. And then that would point to that muscle being involved in that elbow pain, even though that muscle is responsible largely for finger and wrist movement. Okay. So lung 10 is the motor point here. of extensor carpi radialis longus. That's what we're aiming for. Extensor carpi radialis brevis is a little deeper. So it's just slightly ulnar to large intestine 8, which is 4th and below large intestine 11, in case you forgot. And there's just a little tiny area that we can kind of sneak in and needle that because it's underneath those other muscles. And the extensor digitorum communis, that's the one I was just talking about. It extends the wrist, and it extends all fingers except for the thumb. So if you wanted to test that muscle, you could test it at the wrist, or you could test it at the fingers by having the patient try to extend the wrist or extend the fingers against your resistance. And it might refer pain up to the elbow. So this is another cool point to find that's like at a triangle. So the ulnar tip of an equidistant triangle from lung 8 and 9. So the bottom edge, oh, here, I put them in here. So the picture where the muscle's isolated, I put in roughly where our lung, our large intestine 8 and 9 are. Okay. Extensor carpi ulnaris is along that line, but it's a little, we're inching over to the pinky side. So it's just slightly ulnar to Sanjiao 9, which, as a refresher, is 7 cun above Sanjiao 4, so 7 cun above the wrist. Now, these are just a handful of muscles in the hand that I want to point out just because we have some points, some acupuncture points that are great to access them. So the dorsal interossei muscles, they're responsible for extension and abduction of the interphalangeal joints. So they're actually, to reach them, they have 8 motor points. So they're the Shangbashya. So they're proximal to the Bashya, but you kind of, instead of, I don't know if you can see my hand. So the Bashya are essentially in the yin spring region, right, of the hand. And then if you go a little bit proximal, and you're on the line between Sanjiao 3 and extra point Logen. So that's how far proximal you want to be. So that's a good landmark. You can locate Sanjiao 3. And then these motor points, you can needle. They're kind of, the heads of the muscle are against the edge of each finger. So you aim your needle obliquely, just a little bit, a half an inch towards the metacarpal bones in each direction so that the needles form a little X when you're needling them. So there's 8 there. They're definitely spicy to needle. So when you're needling the hands and the feet, you want to let the patient know that they're going to be strong, and they need to be, right? Because we need really, really loud sensory information to our hands from the brain. So, but if somebody's experiencing a lot of hand pain and stiffness, not a bad idea if they can tolerate it to get in there. So you can also access the palmar interossei. So you have the same muscle group on the palm side. So you can access the palmar muscles by going just a little bit deeper through the top of the hand. And I think you can do kind of the same thing on the palm of the hand and that same line to access the other side of those muscles. But I think it's probably a little bit more comfortable to needle the dorsum of the hand than the palm. But But, if you just flipped it, you could needle the dorsal or palmar interossei the same way. I think I hear someone in the chat or something. Okay. You could definitely use those points. Yes, I use with rheumatoid arthritis for sure. I use the Boschier a lot with rheumatoid arthritis. And I think, I kind of prefer the Boschier for that situation because they're closer to the joints that are actually going to get kind of swollen. The interossei are, they're closer to the palm. So, yeah. I mean, you can use your judgment, but yeah, you could absolutely use these for sure. Or just, to stimulate blood flow in these muscles and connective tissues deep in the hand that really don't get a lot of it. The lumbricals are another muscle group that you can access through the fascia. You just go a little bit deeper. And I don't have a picture of those here, but if here's what I'll say. If flexion and extension is a little stiffer or more painful, I would do the fascia, and you could needle the lumbricals by going deeply with those. But if abduction and adduction of the fingers and this like open spreading the hand is a little bit more painful, you could go into the interossei and needle those. So that would maybe be the difference. But I think the fascia, maybe even start there for patients because, that's a good introductory to needling the hand. I wanted to show you this muscle here, the abductor digiti minimi. Look at that point. That's right between SI3 and 4. So I love needling this region to treat the spine distally. But this little muscle is responsible for abduction of the pinky, which is kind of tricky to do. But yeah, I just wanted to point it out just because of where it is in relation to SI3 and 4. It's nice to know what's behind there, right? And then what is this one? This is lung 10, right? Opponens, pollicis. So this is this little muscle is responsible for opposition of the thumb. And so for resisted range of motion there, if somebody reports, pain and arthritis in the thumb, we don't have to memorize any particular test, but you could just ask, okay, can you touch your thumb to your pinky? Is that painful? And then you could try to pull the pinky away from the thumb and test that range of motion and that muscle strength. And, that might tell you that, maybe the muscle is the nerve pathway in the muscle is a little bit more damaged, or, sometimes you can get atrophy in some of these muscles if there's too much qi and blood stagnation that's not adequately nourishing the nerves. They could be deprived of oxygen. And, I really, in very simple range of motion tests like that, I'll often treat it. You can needle into lung 10, which is sensitive, but you can get in there, poke around, and then try at the end of the treatment to see if that muscle's any stronger. So yeah. Okay, so now we're going to talk about a couple specific diagnoses and how to actually test those orthopedically. So the first is de Quervain's. You're going to see this a lot. And Finkelstein's test is the one we do for this. So the cause of de Quervain's is repetitive strain of the thumb and wrist and actions involving thumb abduction and extension and ulnar deviation of the wrist. So fishing, that's, and frisbee, golf to some degree too, but space bar keying a lot, and bartending and hairstylists that often use scissors. This is a really big one, and uh-oh. I think there was just an accident outside my office and it sounded really terrible. So I'm going to just go peek really quick and see if everyone's okay. So hold on 1 second and say a little prayer. Okay, this is probably a 911 situation, and so let's take another little break, okay? And I'll report back in a minute. So just keep an ear out for me. Sorry, guys.
Okay, good luck. Thanks.
Okay, thanks. Woo-wee. Is everyone back or here with me? That was crazy. There's good. Thank you. I'm a little shaky. There was a pretty serious accident just outside. I think you guys heard it. And somebody in the car, she was in shock and she's injured. And I don't know if it's her lumbar spine or her hip or what, but she, you know, when people are in shock, they try to run. And so we called 911 and they're over there right now, but she was trying to get up and flee from the scene. She was in a lot of pain. So we got her calm, and you don't want someone to move in that situation, right? You want them just in a resting position with their head and their neck supported until somebody can come. So we were holding her neck, and a couple of us had to actually hold her down and breathe with her while the medics are arriving. There's a lot going on right now. I hope she's okay. She seems okay. She's just in shock. And so let's just send lots of healing energy and light to all the people that are struggling in this very moment. Oh my gosh. Okay. So where were we? I don't even know if my screen is still being shared or not. So give me a second. Whew. To get this back up. Man. Okay. De Quervain's. So, this a lot of times with de Quervain's as well. I see this in people that don't play these sports or that don't do these things for a profession. Oh yeah, holding an infant. That was another one. So this action of like maybe lowering an infant into the crib or whatever it is. This can be somewhat spontaneous too, I think, just based on some of the patients that come to mind that have presented with this. But this is going to be classic pain in the region of lung 7. So on the radial side of the wrist. And so what happens is that the tendon sheath, so each tendon is kind of wrapped in this like conduit, right, of connective tissue, and they're supposed to slide around freely in there, right? So the extensor pollicis longus and brevis tendons are the ones implicated here. And they become just kind of inflamed and painful, and they start to become fibrotic and thicken. So I think we feel that a lot if we're doing some gua sha in a distal to proximal direction, always, right, along the trajectory of lung 7. We feel a lot of little gritty bits in there, right? It's common. So crepitus, creaking, cracking, popping with thumb abduction and adduction might occur. So again, a manual muscle testing of thumb motion and wrist, like radial deviation, might kind of reproduce pain, but that's not necessarily going to tell us much in the way of, you know, exactly. It'll help determine maybe the cause of or the general vicinity of the injury and maybe what structures are involved. But in this case, it's the attachments, the distal attachments of these tendons that are involved. I, 'cause, 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 I, 'cause needling classically in the region of lung 7, doing some tuina gua sha towards the heart always. And needling in lung 5 is a great point as well for this. LI4, LI5, lung 10, we can surround it, right? And then I'm just kind of giving you the agonists and antagonists that might be involved in this. Ulnar deviation and radial deviation, again, is sort of done by groups of muscles. So if you tested resisted range of motion, it would kind of get you there. But you want to kind of follow the pain pathway too to determine what end of those muscles might be the most injured. And herbs are great because these tissues are relatively superficial. Herbs that stimulate blood flow and are warming are really, really helpful. I made my last patient that has DeQuera veins, I made her a little like concoction. I sometimes do that. I have little glass vials and I'll put some of my massage oil that people really like. It has a low level of CBD, but I put some dragon's blood in there and some other warming herbs and kind of shook it all up and made her a little topical rub, and it helped a lot. So Finkelstein's test. So we're not so much testing. We really want to test range of motion in a vulnerable position for these tendons, right? Not so much the muscles involved. So it's easier. I don't think we need a video. This is super, super easy to do. You're just going to have the patient place their thumb in a closed fist in a neutral position with the thumb fully adducted, not in complete opposition to the pinky, but just make a hand around the thumb or the fist around the thumb, and then have them actively deviate the wrist to the ulnar side. Doop, doop. Directing them to tilt their hand downward. So like pinky towards the elbow, right? And you can do some resistance there, but I think passive ulnar deviation would tell you what you needed to know. And if pain is felt in the region between lung 7, lung 9, and LI5, it's a positive test. And that test stretches those tendons, right? The abductor pollicis longus and extensor pollicis brevis. And we talked about that, how ulnar and radial deviation recruit groups of muscles to perform those actions. Carpal tunnel. Okay, we'll talk about this again and again and again. Compression of the median nerve. So if somebody comes to you and they say their carpal tunnel is acting up, please check the neck. We just want to make sure, even if someone says, oh, well, I don't have neck pain, I just feel numb in my fingers, you still want to check the neck. Because if something's advanced enough in the spine, they might not even feel pain anymore. They might just feel numbness. And that's a way worse position to be in, possibly irreparable, than actual pain, right? So just rule out the neck. And then this is really clear usually. So first let's back up. So the cause is compression of the median nerve through the carpal tunnel. And the carpal tunnel is kind of just distal to P7, right? In kind of the base of the palm of the hand. And there's a picture of that there. That's the flexor retinaculum. It's a little like bracelet of connective tissue. And look at all these little tendons and nerves that sneak through there, right? So it's kind of like up here at the thoracic outlet. There's like bundles of tissue that get squished in some of these places. So that's why it's important to tease out where these nerves and vessels and structures are getting irritated so that you can effectively treat them. So repetitive strain definitely is part of this. So a lot of typing, even though I would say like typing and keyboard work, that has a lot to do with finger motion and, you know, muscles that are attached to the elbow, where carpal tunnel, I guess you can also have, like, if you're constantly in extension where this is being tightened, or if you're in, I think flexion would be more relieving. So if you're in a position where, you know, someone's trying to be maybe ergonomically correct and type on like a keyboard that's a little bit raised, but the hands are sort of, you know, the wrists are extended a bit, that's going to put more pressure here. Carpal tunnel is really common in pregnancy, and also hypothyroidism and diabetes, just because swelling in the hand can just crowd the space, the very narrow space between the carpal tunnel space and those nerves. So it's going to clearly be numbness in the thumb, the index and middle finger, and or radial half of the ring finger. And if it's not that, then it might not be carpal tunnel. And there's so many conditions that might cause numbness in the thumb and forefinger, or just the middle finger, right? But very rarely do you involve half of the ring finger, and it's the radial half. And that's a weird thing that patients are going to point out. They're going to say, oh, might sound strange, but it's like half of my ring finger, right? And maybe they don't have carpal tunnel, but, you know, that's the most common condition you're going to see that affects the median nerve. So it's just a funky little pathway, and I want you to know it. Yeah, so computer's gonna probably cause, if they already have carpal tunnel especially, it's gonna trigger it. And sleeping too. And then cycling is actually, that can be kind of a common cause of a lot of wrist injuries, just because of the pressure on the handlebars. So pronator quadratus, we talked about that. We're gonna look at that motor point again. That is the one that is located next to P6. You got to be really careful needling it. And there's a taping technique too. I'm not going to get into that so much in this class, but it's super easy. And you basically have the patient oppose the thumb and pinky and have them maximally flex the wrist, right? And you can just intuitively think about what that would do to the carpal tunnel space. It would open that up, right? And so if you tape it like a little bracelet, that can help kind of relieve tension off the carpal tunnel. So the Phelan's test, the reverse Phelan's, and the Tunnell's sign are the ones, the tests we do to check for that. They're pretty reliable and they're very easy. So Phelan's, just remember, is reverse prayer hands. So you're just going to have the patient place the dorsum of their hands together in extreme flexion with the elbows at 90, and hold that for 30 to 60 seconds while you're chatting. And that may or may not do it, right? It's supposed to compress the median nerve. If you oppose the thumb to the pinky, it's going to open up that space. So don't have them do that, but you just have them squish, 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 and see if that reproduces their pain. And if not, do the reverse Phelan's. So this is prayer hands, right? And you want the elbows really at 90 degrees. And you place the palm of the hands together with wrist and extreme extension. And you hold that for the same amount of time. So that should, if it's unclear where the numbness is happening, that should make it clear. They should say, oh yeah, I feel it in the thumb, the index finger, and the half of my ring finger. And then the Tunnel sign you can do in a number of different places. You're just going to tap over the carpal tunnel zone, over the median nerve, or you can hold firm pressure over it. So you tap 4 to 6 times, just like we do over SI8, right, for ulnar neuritis. Or you can, I would use 2 thumbs, one on top of the other, kind of like that, to compress this area and hold it for up to 30 seconds again. And that should also compress the nerve. You don't have to do all of these, but if you're not getting what you're looking for, you can start to go through them. You can do them in whatever order you want. And you may only need one to confirm your diagnosis. Guillain Canal syndrome is distal ulnar neuritis. So ulnar neuritis can happen when the ulnar nerve is compressed in the elbow, but it can also get compressed further down in what's called the Guillin's canal, right? And there's a Wartenberg sign that we kind of use when we test the cervical spine. A myotome in the cervical spine. It's similar to Wartenberg sign. But again, anytime you're having numbness or tingling in the arms and hands, rule out the neck. So if flexion is like, yep, I feel it in my pinky, then, you might, or extension and rotation, you feel it in the pinky, you might want to think about, where it might be coming from the neck as opposed to an ulnar nerve, either in the elbow or wrist. So this groove that I'm talking about is between the pisiform and hamate bones. So it's a half to Wenson distal to heart 7. So it's kind of like ulnar to the carpal tunnel space, just towards the pinky. So again, cycling, it's sometimes referred to as handlebar palsy. Pressure on the handlebars can sometimes compress the ulnar nerve at the distal portion. So you're going to have pain and weakness in the pinky and ring fingers in this case. And it might be hard to spread the fingers, and the patient might report difficulty gripping, like they might feel a little uncoordinated. Maybe the strength in the rest of their fingers is okay, but the ring and pinky finger are still a little weaker. So again, I can't emphasize enough, you want to just really kind of differentiate between compression of C8, which would really follow a similar pathway. And that comes down to what reproduces your symptoms. So if you do Tunnel's sign down here and compress in that area of the Guillin's canal, 0.5 to 1 cent distal to heart 7, and that reproduces numbness and tingling in the pinky and ring finger, then you think about compression further down versus range of motion in the neck. And then thoracic outlet syndrome, I throw that in there, but again, that's all over the place. So that's the one where you're like, that's not fitting into the cervical nerve root picture or the peripheral nerve root picture. It's just kind of the whole hand, and it goes to sleep, easily when they may be laying on that side or washing the hair or something like that. And then just as a practical thing, if your patient has, if this is provoked by cycling, you can have them wear padded gloves when they cycle if they don't already, and that can help. So the Baxie are great here. And then Jingwells on this pathway. So the treatment approach, I'm sneaking in here kind of individually to give you a sense of like differential diagnosis specific points. And then when we talk about TCM patterns, you want to overlay that generally on top of whatever you're actually seeing, because this can be Qi and blood stagnation and deficiency as well. So can carpal tunnel, right? So you're going to draw from what you know structurally and biomechanically of these individual problems, and you're also going to draw constitutionally and diagnostically from the TCM patterns that maybe these patients, the pain is against always a background of some TCM pattern, right? So Wartenberg sign, here's a video of it. I'm not going to play it because I want to get through this. It's really, you can watch it later, but it's very easy. Passively, just have them rest on something flat, the treatment table or a table, and passively spread their fingers. And then instruct them to actively bring them together. And the test is positive if they can't adduct the pinky and bring it closed, right? So that's similar to when we're testing for the C8 dermatome. You know, we're testing the interossei muscles by having the patient spread their fingers wide, and we're trying to squish them together, and then we have them hold them tight, and we try to, you know, pull them apart. That's the cervical dermatome or myotome test for C8. But in this situation, it's a passive abduction. And then we try to just have them bring their fingers together. And if it's just the pinky that's having a hard time, we might just be dealing with an ulnar nerve. So you can watch that later. So Tunnel's sign, again, we use this in the ankle, we use it in the elbow, we use it in the wrist. You're just gonna tap or hold firm pressure over whatever region, a little bit radial to SI5 and distal to heart 7, right kind of near the pisiform bone. You can kind of feel it. So same thing, tap or press for 30 seconds. And see if it reproduces pain or numbness or tingling. Ooh, I'm going to correct that. Positive test. I copied that over. Positive test if it's in the ring and pinky fingers, not the radial half of the ring finger. I will not post this until that is corrected. Okay, trigger finger. I want you to know about this. I treated it a handful of times actually in the clinic, and Jeffrey Pong was my amazing instructor. And he just, you know, he had me e-stim, Osher points surrounding the trigger finger, and of course herbs, moxa, all of the above. But trigger finger is interesting. So the formal name for it is stenosing tenosynovitis. And the connective sheath that is supposed to protect the tendon and help it glide smoothly, it gets inflamed, right? So the tendon can't glide through that little zone. And so what ends up happening is the finger kind of like gets stuck and locked in a bent position, and the patient can't really straighten it. And then all of a sudden it will spontaneously pop back into a straight position like a trigger, right? Trigger finger. So, the setup for this is like stiffness and crepitus and clicking, popping of the fingers. I also see very commonly patients will say, oh, I have this little nodule in my palm, right? What is that? Don't ignore that as a sign that, that it could advance to trigger finger. And I'll spell this. I have to stop sharing in order to do it. So, Dupuytren's palmar fibromatosis is different than trigger finger. I don't have a slide on it. Dupuytren's slash palmar fibromatosis. Not the same as trigger finger. It's similar in the sense that a patient might report like early on, like little nodules or bumps in the palm. Dupuytren's, it's hard to pronounce. It's very gradual and it doesn't affect the tendons. It kind of happens slowly over the course of time, and it can involve multiple fingers, but it's just basically like a thickening of connective tissue in the palm that just kind of causes the fingers to curl in and contract. And actually, if you try to straighten them forcefully and you get in there with like a lot of, you could kind of get in the palm with Tuina and maybe some gua sha, but if you try to forcefully straighten the finger in that case, it's gonna, I wouldn't do that in either case, but it can actually make it worse. So you don't want to force the fingers into extension, but you really want to get into the palm and try to break up any adhesions. Yeah. Did I spell that wrong? Dupuytren's. Yeah. Yeah. Melinda, is that you?
Hi.
Hi.
Yeah. I just said Dupuytren's. Question: We as acupuncturists do not do ultrasound, right? Like we do e-stim, but not ultrasound, because ultrasound would help.
Oh yeah, it could. Yeah, I don't think that's actually in our scope. Unfortunately, Moxa is, and e-stim is. But yeah, that's a good.
Darn, I can't hear you.
Oh. Oh, am I back? Can you hear me?
Darn, I can't hear you if you answered. Maybe it's on my end, but you kind of froze. So if you answered my question, I didn't hear a thing.
Okay, I'm gonna restart.
I can hear you, Jen.
Oh, you can?
Yeah.
And everyone else?
It might be.
Yeah, I can
Okay.
hear you fine.
Okay, good. Okay, yeah. All right. So yes, no, it is not in our scope of practice, but it's great to connect with other people, maybe that can utilize some of those things. But moxa is great. Topical herbs are great, and even internal herbs. So let's see. So back to this. Yeah, so no forceful manipulation. Don't do that. But if you do, if someone reports stiffness, another thing I really, really love to have patients invest in are those paraffin wax baths. They're so great. And I used to have one in the office that I removed in COVID, but they're not that expensive. And they warm, like you can feel the warmth almost to the bone. They're so great. And it's just this little bath and it heats up paraffin wax and you dip your hands into it. And it's the funnest thing to peel it off after it cools. And if you're just using it yourself, you can throw it back in to to the bath. In a clinical setting, you want to throw the wax away, of course, but it's a great thing to have in your office, and encourage patients to warm their hands, because these little thickening, like these adhesions in the connective tissue in the hand can lead to really kind of obnoxious contracture of the fingers over time. So you definitely want to make sure, but I raise trigger finger, one, because it's common, and two, because it can be a complication after the first 6 months of carpal tunnel surgery. So yeah. So this isn't permanent. The finger's not always bent. It kind of, like I said, spontaneously resolves. So I think we can minimize. Okay, I never learned about this in trauma and ortho, but I've seen it so many times that I want to bring it up to you, because patients, particularly women, middle-aged women, I think it's more common, and I don't know exactly the age range, but there's something called Achenbach syndrome, or paroxysmal finger hematoma. And it looks, here's a good picture of it. This is similar to what I've seen. It looks like very severe, right? And the patients will be scared. They'll say, oh my gosh, my finger's bruised. I don't remember doing anything. And it's mysterious, but it's a thing. And you can assure them that it will go away. And they're going to be okay. In the context of everything else going on with them, you may need to rule out other things, but this is pretty easy to recognize, but just by observation. And it resolves, but you want to strengthen the spleen for sure in this case, and just strengthen the blood vessels, right? So I would even do, you could even do spleen 1, and I would do like blood movers topically. But I'm not going to really test you on it, but I want you to see it, because years down the line, if someone comes into your office with this crazy black and blue finger and they ask you, oh my gosh, what is this? Or they tell you about it, you can assure them, because I've seen this I don't think it's very common, to be honest, but common enough that maybe, I've just so happened to see it more than once or twice or even 3 times. It's very, very common. As are ganglion cysts. You're going to see these all the time. It's repetitive load and strain on the wrist, carrying trays, weightlifting. I've seen this actually a lot in massage therapy. So we need to be careful too, as practitioners, that we don't necessarily give ourselves a ganglion cyst with overloading our wrists without stimulating blood flow and chi afterwards when we're working so hard. But it's a degeneration of the tendon sheath, and they're benign. It's a pretty good picture of it. They can present anywhere really in the wrist. They can come up like really quickly. They're quick to form, and they're freely movable. And they can get big really fast, depending on how much stress is put on the wrist. They're not usually painful. They don't usually really impair somebody's ability to work, but they can grow to a substantial size. And in that case, they can just get kind of uncomfortable because of the pressure. So we can think of this as phlegm, right? It's thicker than synovial fluid. It's really kind of gelatinous, and they can be aspirated, but they usually come back because it's not a draining issue. I think I heard the chat, but I can't see it. So if someone has a question, yell out. Otherwise, if it's a comment, I look forward to reading it in a minute.
Jen, they
oh.
can be big enough to inhibit movement, extension of the wrist.
If it's big enough and if it's in that area, but it's not, they're not always there. They can be in many different places, but in here is a common place. And yeah, if it gets big enough, it can, like I said, crowd the area. But they're, you know, not all of them are that severe. And you know, I'm not saying it's not a problem. It can be for sure. But depending on where it is and what it sneaks between, it may or may not be that much of an issue. But you know, of course, you know, patients can be self-conscious about them, and you definitely want to address it, because again, they can keep growing, and they're going to in response to movement of the wrist. And so if they form in the first place, it's likely that, you know, there are activities in your life that are going to continue to exacerbate it. So it's tricky because we technically, it's out of our scope to aspirate it. I know that there are ways of treating these in TCM and other ways. But just like I said, just draining it, it's likely to come back. So removal of the actual joint capsule or tendon sheath is kind of what ends up doing it if it comes back. But we can manage it and keep it at a reasonable size, if not shrink it altogether, at least by 50% by turtling it. Surround the dragon. And then we want to address phlegm and cold. So it's, you know, and certainly if somebody gets surgery or if they get it aspirated without surgery, have them come see you. And then, we can, by needling those areas, hopefully, make it harder to come back. Does someone have a question?
Now, Jennifer, when you turtle the cyst,
Yeah.
do you, does the needle go right at the edge or right on the outside of the edge?
Oh, good question.
Of the cyst?
Yeah. It's hard to know exactly where, like, I kind of aim. So let's see. I don't know if you can see my cursor. I would aim at the base of it, but and same with like a hematoma, or some like I was talking about, like bites, mosquito bites or spider bites. If you're turtling it, you want to go with the perimeter, but you can aim to get it kind of underneath the actual mass or lesion that you're trying to needle into. And then in this case, you can go directly into it. And you can do one right on the top, and it can kind of, you know, it might drain a bit that way. We're not aspirating it, but yeah, you're going around the base, but you're like poking a little hole in it, right at the base of this little balloon.
Yeah, it just seems like a sneaky way to aspirate it, but I get what you mean.
It's maybe it is. But you know that yeah, that's true. It's true. And that's where we need to be really clear when we're charting what our goals of therapy are, right? And you can, in this case, you know, to really protect yourself, or, you know, ethically, if you want to be less, if you want to be more conservative, you can write, you know, in the chart notes that you're aiming for the perimeter, you know. The goal is not to aspirate or whatever it may be, but yeah, you know, I mean, I don't think it's entirely, I mean, we're not, I think the thing that gets us in trouble is an actual needle that, like, not a filiform needle, but like a hypodermic needle that we're sticking in and drawing fluid out. We're not doing that, but we have every right and authority in our scope of practice to stick filiform needles into the body, right? And if we pull them out and there's a hole in the skin and some fluid leaks out, that's, you know, that's different than actually aspirating fluid through a needle. So I think we're okay. Okay, and then again, I just remind you, if you have a question, a wonderful question, or even not a wonderful question, shout out.
Jennifer?
Yeah.
So yeah, my question is, on the previous slide, it says it's a cold condition.
Yeah.
Would it be in TCM terms congealed
Yes.
thick fluids, or would it be congealed phlegm?
Congealed phlegm, like, I think an extension of cold, right? So you could start with lack of circulation in the wrist, lack of blood flow, lack of chi, and it can, in that terms, it could be a little cold. And then, you know, that when cold starts to accumulate, it can congeal just like heat can, right? So, yeah, if it actually becomes a ganglion cyst and you actually look at the material that's in there, it's like really gelatinous and jelly-like, definitely phlegm, cold phlegm.
And is it made of fluid that is supposed to be in the body, just it's basically accumulating? Or
Ooh, that's a really good question. I think I'm inclined to say yes. But you know, biochemically, now I'm gonna have to look. You know, I know it's different than synovial fluid because it's thicker than that, but I'm wondering if it's kind of like stagnant synovial fluid. I don't know if maybe it has, you know, any lymph in there, or you know, when I'm 7-starring, sometimes you get clear fluid that's released, right? So we could have a lot of different fluids that sort of congeal, just like blood can. And I think I mentioned briefly, it's so crazy about hematomas. If blood accumulates for long enough, sometimes bone can start to grow in there, right? So like, I think all of the fluids in our body are supposed to be there. But if they're not flowing properly, just like in nature, you know, stagnant water, you get this sludge that just kind of accumulates, and maybe it turns to something else when it combines with other pathogens. And so in our case, it's phlegm, but it's not the kind of phlegm you're going to sneeze or cough up. But yeah, it'd be interesting to look at the types of cells that are actually in there. I don't know if that answered your question, but I'm inclined to say yes.
Yeah, it was sufficient. Thank you.
Okay.
Jen?
Yeah.
Yeah, I've had experience with these.
Yeah.
When they burst or they're drained, you don't even have to. You don't need a hypodermic. And
right. No, you don't. It gets
flushed with the filiform, it just gets reabsorbed and flushed out wherever it needs to go.
Yeah, absolutely. And I've seen patients that have they've had spontaneous resolution of their ganglion cysts by accidentally, like,
Falling.
trauma to the wrist. Like, oops, I knocked my hand against this book or wall or whatever. And
back in the day, the nuns used to use a Bible to smash.
Yeah, there you go. Yeah. So, I mean, a good whack could be enough to break it up. And, you know, I mean, I've seen them that don't come back, but it's good to know that they could. And it may be likely, but if we kind of treat those areas and just continue to encourage chi and blood flow in the areas that are more vulnerable to formation of the ganglion cysts, then we can certainly help prevent it from coming back. Yeah. I love your questions. All right, so I'm going to get through the rest of this lecture. Scaphoid fractures, this is the last one. When someone has a Fuchs injury, again, Fuchs meaning falling on an outstretched hand, this is the most common fracture. You can have a distal fracture at the radius, but a scaphoid fracture is a tricky one because it can be mistaken for a wrist sprain. And it might, the patient might not realize they broke anything. And on top of that, even if they suspect or they go to urgent care right away and they get an x-ray, they might not see it. So, if they don't get an x-ray, sometimes patients might just be a little slower to get themselves to urgent care or to somebody to check it out. But delayed healing is, it can be a red flag. You can have non or delayed union healing. So the bone's not going to heal in the same place that it might otherwise. And that happens in the ankle too, and with different bone structures. But what we worry about here is on the less risky side, it could just set the patient up for arthritis, a lifetime worth of arthritis in that joint if the structure is malaligned and heals that way. But the worst case scenario is necrosis. So we'll talk about that. But the most reliable way, if you suspect a fracture, is really tenderness to palpation. And I know that sounds silly, even more so than a tuning fork. And a tuning fork is really going to get some acoustic palpation deeply into those structures. But tenderness to palpation, the argument there, though, is there are so many things that are tender to palpation, right? But if you palpate the scaphoid in the region near lung 5 or lung 9, depending on, where, maybe I meant to say LI5, because you can have a distal and a proximal. I think lung 5 is appropriate, with the elbow, but I'll fix that too, because I think arguably near large intestine 5, the anatomical snuff box, and lung 9 on the inside of the wrist, that's where you're going to feel pain. So you want to extend their thumb too while you palpate there. So have them have the thumb out while you're getting in there and checking. And then resisted pronation may also reproduce pain and weakness. Again, going back to that question, how many things might be involved in pain with resisted pronation? I mean, so many muscles, bones, but it kind of shrinks the tissues you might be looking at, or narrows your view, right? So x-rays definitely are helpful for this, even if they've already gotten x-rays. If it's not healing and it's persistently painful, and the patient might then go get it checked out. And then if they come to you in a cast, don't wait for them to take it off before you treat them. You can treat the fascia because usually it's the type of cast where the fingers are exposed. You can get to LI11 and you can usually get to lung 5. And then treat the opposite thumb. And make sure they don't take NSAIDs because that can delay healing time of bone fractures. GCM herbs are by far much better. Zyflamend is great, but we have a lot of bone healing herbs, right? Great Mender is really good for that. So these red flags should stand out always. So the red flag we worry about with a bone that doesn't heal properly is avascular or aseptic necrosis. And that is essentially death or destruction of bone tissue due to lack of blood supply. It sounds very dramatic, but it is. And you might not feel anything at the beginning, but it can progress into pain, swelling, numbness, and that would have to be confirmed by an MRI, not necessarily an X-ray. So, but that's if this goes on and on and on. So definitely know what avascular necrosis is and what might that a scaphoid fracture might be a red flag. So occult fractures, meaning this, and this some of you might recognize from review and assessment, this slide. Occult fractures of the scaphoid of the wrist are meaning an undetected fracture that was maybe missed by X-ray. They're susceptible to, I'm just going to say all of the above: malunion, delayed unition, non-union, or avascular necrosis. I have some editing to do before I give you this. All right, scaphoid fractures of the wrist are often missed because, I'm going to just tell you, initial X-rays might be negative, or they're often falsely diagnosed as wrist sprains. But they are going to hurt when carefully palpated. They will hurt when carefully palpated. So carefully palpate. All right. So, oh my gosh. Treatment methods. We already went through these, right? Last time. These are kind of the same. These are all the same muscles involved with wrist flexion and extension, but I'm putting them in here too for some context. And I think pronator quadratus is the one that is most commonly used in carpal tunnel syndrome. So that's the one, slightly radial to P6. So you're going to push flexor carpi radialis out of the way. And you're going to needle right next to P6, straight down very slowly until they feel a little ache. And they might feel a little whoop of the median nerve on the way down, and that's okay as long as you back the needle off, or as long as it kind of goes away. You do not want to traumatize nerves with our needles, but it's okay to brush past them and say hello, but don't mistake them for chi. It is chi, but not the chi, right? So here is, in the context of the rest of our amazing points, here are the motor points of those interossei muscles, right? The two between each finger, proximal to the fascia. So here they are for reference. And those were the only ones really in the dorsum of the hand. And then the lumbricals, you can access on the palmar side between each finger on a line between SI3 and LI3. Or, like I said, you can go down through the fascia, perpendicular. Or I guess, well, it depends on where you insert your needle. But this is where you're aiming, right? So if you're going through the yin spring points, you have to aim down towards the palm. And then at lung 11, right, is the motor point of opponens pollicis, and SI3 is right over here in the line of the lumbricals. And then I keep forgetting to mention the ear. There's so many ways to treat our patients, right? So that's the easy part. We know this. So just to give you a refresher, the fingers are here in the ear. And top to bottom is thumb to pinky. And then the points for the hand and the wrist are here. So just to refresh your memory, but they're all here. So you can refresh your memory with where they are in the neck and in the shoulder, the arm, the elbow. And then this again, I'm just throwing this out there just to, because repetition with this is easy, or that's what it takes to have this come easy. So again, thinking about the chi clefts as this area where chi and blood kind of pool, and we want to move that through by using the anatomical clock and the midday, midnight correspondence. So in the heart channel, if you have ulnar hand pain in the pinky, we're going to find heart 6, which is the chi cleft on the affected side. And then the opposite side, we're going to go across to the gallbladder and do the luo. And so I'm giving you examples. Am I going to make you pull this out of your brain? No, I'm not. But maybe, just maybe, I might give you as a bonus question this clock to refer to. So you'll have that. And I might even give you the chi cleft point, because again, this is not review and assessment. I'm not testing you on whether or not you even know what a chi cleft is. You're going to have to worry about that in other classes. So I might give it to you, but just know that concept. Chi cleft on the same side. And if I gave you, this clock with multiple choice, I bet you could do it. I'll try to keep it as a bonus. Okay. So there's a few patterns. Some of these are redundant, but this is so important in the context of some of these specific ailments. And I know we only have like 5 minutes left. So we're just gonna respectfully kind of run through these quickly. But this is going back to your question about the ganglion cyst. This is the pattern you want to think of for accumulation of phlegm cold, right? With chi stag and maybe some underlying blood deficiency. So chi and cold stagnate from repetitive strain or overuse, and the warming function of chi then can't happen, right? So cold accumulates in the Jingluo. And then fluids, so yang is movement too, right? It's not just warmth, it's not any one thing. But if fluids can't circulate, they're gonna back up, and then phlegm might build up if it starts to, depending on what fluid is built up, right? So if it's in the tendon sheath and you have a lot of like synovial fluid that's kind of gliding around in there, if that backs up, that can kind of turn into phlegmy buildup. And then you can kind of assume, at least locally, if not systemically, that these patients have a little bit of underlying blood deficiency to this region. Because if something's blocked, then blood's not going to get there. So you have stagnation, but you also have deficiency. So if you can't nourish the sinews, they're going to become dry and they're going to become brittle. And if you're yin deficient anyway, constitutionally, you're going to have that. So all the things we know, I threw in the turtle technique here too, because if we're dealing with phlegm and we can kind of see it as like these, little accumulations and nodules, we can surround the perimeter of them, right? But we have phlegm points, among them being stomach 40, spleen 9 for fluids in general, and then moving with LI4. E-stim is great to break up some of these accumulations, and moxa. And then you want to nourish liver, blood, and tendons with our classic points. These are all suggestions. So you don't have to memorize all of these, because if I ask you about a treatment protocol and I give you a diagnosis, I think your TCM knowledge thus far, no matter where you are in the program, I think you can, stomach 36, liver 3, liver 8, some of those tonifying points will come to mind. So this is another sort of newish pattern, Qi and blood stagnation with latent heat and local fluid obstruction. This is like a broken bone in the first 7 days. So we've got a forceful trauma to a bone or a soft tissue. We've got Qi and blood stagnation in that area. Pain can be sharp if you move it, or really just dull and achy at rest. And then heat and local fluid. So this is an acute inflammatory response, right? So instead of cold accumulating, you're going to have heat and local fluid obstruction. So the accumulation of yang qi, because your body knows you have an injury, so that yang is going to kick in, it's going to send all sorts of amazing inflammatory chemicals to that area right away. So you've got a flood of yang to that area, and then it backs up, right? So local swelling, heat, acute inflammation, and you could have, swelling in the fingers. So this is where the Jing wells, bleeding the Jing wells, or applying moxa to them, and those Shi cleft points to address acute pain and blood would come in really, really handy. And then tissue specific treatment, right? Based on what it is and where it is. And UB11 to build the bone. And GB 34 and 39, I love to nourish marrow and tendons, deep nutrition, right? With acupuncture. And spleen 10, I love to regulate the blood. It's mostly in the uterus, but, it also cools the blood. I think of that point like Chirshao. And I know we're pretty much out of time, but we're almost there. So this is pretty much from last time. So bear with me for another minute, just in honor of the person that needed our help in the accident. I hope she's okay. Oh my gosh. So this we've already talked about, but it applies to all of these injuries. So you just want to think of, about some of these patterns. This one too is from the past. But if you read it and compare, I'm kind of thinking about it in the context of the wrist rather than the elbow. But same kind of thing. And when we're talking about underlying qi and deficiency and all of those things, you want to always think about the lifestyle of the patient. What are they doing to support their well-being and their healing? Are they getting enough rest? Are they getting enough rehab, the proper rehab? Are they getting enough nutrition? All of that stuff is going to really help or hinder someone's healing. This we've talked about a lot. This can apply. These are like heavy, stiff, achy, creaky, cold, damp, painful obstruction, numbness, tingling, all of that. And then I threw in Dongui Sini Tong. I think we all know this formula, but I think of this for the hands. This is mostly for cold extremities. It nourishes blood and unblocks the vessels, disperses cold, but you can modify it to be more of an orthopedic treatment if you want to bring qi and blood to the extremities. And a lot of people have cold hands, right? Cold hands, cold feet, cold tendons, contracture, trigger finger, cold accumulation, phlegm, all that stuff. And here are your key points. Here we go. I can pull these up, but I think what I'm going to do is add them to the compiled key points list for you. And then that way you can see them all together rather than having to go into all of these slides. So you're welcome. Thank you. Wrist and hand, yes, will be on the midterm. Absolutely. Everything thus far. So I'm going to post that for you ASAP. And I'll stick around for a second if anyone has any questions, concerns, fears about the midterm. But don't worry, you guys are going to be fine. And you're welcome.
Thank you, Jennifer.
Thank you.
Thank you.
I was a little flustered today.
Enjoy your weekend.
Thank you, everyone. You too.
Thank
Have a
you.
good holiday weekend.
Oh, you too. You too. Please be safe out there.
Thank you.
Thank you. Bye.